All right, so the main topic of this video is going to be about a drug called finasteride, which, like we discussed, inhibits DHT receptors or the production of DHT rather, all throughout the body, but it's especially known for its effect on hair follicles and preventing hair loss. Also used for benign prostatic hyperplasia, which is growth of the prostate gland. But before we get into the details about how the drug actually does what it does, I thought this warranted a little bit of background that might be helpful. So the root of all of this is it's an outflow of the production of testosterone. And so as a quick background on this, testosterone levels in a person that's not taking any medications to alter things is kept at homeostasis. Levels can go up and down, but for the most part, it's pretty steady. And the way this works is the hypothalamus, which is a region within the brain, produces a hormone called GnRH, or gonadotropin-releasing hormone. And that hormone stimulates the pituitary, which is an endocrine gland that's not technically part of the brain, but it's very, very close to the brain, basically dangling off the bottom of it. And the anterior pituitary responds by producing two different subsequent hormones, LH, which is luteinizing hormone, and FSH, follicle-stimulating hormone. Those hormones, they got their name from their effects on female reproductive systems, but they are present in men, and two particular effects. FSH stimulates the production of sperm, which isn't really where we're going right now, and LH, luteinizing hormone, tells these Leydig cells to produce testosterone. Testosterone then, of course, goes out into the body and has effects on muscle mass and bone tissue and spermatogenesis and many, many other structures, including hair follicles. Now, if you get enough testosterone that levels are where they need to be, negative feedback kicks in, which just means that testosterone will inhibit the hypothalamus from producing GnRH, and it will inhibit the pituitary from producing LH and FSH so that levels don't get out of control and go too high. All right, this can have impacts like if a person takes testosterone replacement therapy and you're adding a bunch of exogenous testosterone in through TRT, the negative feedback process still kicks in, which means that in someone taking supplemental testosterone, you would expect their LH and FSH levels to go down, which means that their internal production of testosterone would decrease. This happens with almost any drug where it's mimicking a naturally occurring hormone or neurotransmitter. The body will attempt to maintain homeostasis. So the more you take, the less is produced, which in this case isn't really anything horrific, but it does mean that this person is probably going to be taking testosterone supplements for the rest of their life, because as soon as they stop taking the TRT, their testosterone levels will drop dramatically, right? Because now their Leydig cells aren't getting the signal from LH to produce as much, and eventually things would rebound, but they'll probably rebound to where they were before they took the supplemental testosterone, or possibly even lower, right, because of those mechanisms. Okay, so either way, we've made our testosterone. The next thing to realize in all this is, so testosterone is a steroid hormone. The term steroid really just means chemically that it was made from cholesterol. And so you notice all of these steroid hormones, testosterone, estradiol is just the most common form of estrogen, and this 5-alpha-DHT, which we'll get to in a minute, they share that common 4-carbon ringed backbone that came from cholesterol, and we're just tweaking it. Like, so if you notice, the structure of testosterone versus estrogen is actually incredibly similar. There are really only a couple very, very minor differences in the orientation of some of these atoms and what's present, but they're very, very, very close, but they bind different receptors. Because remember, receptors are incredibly picky about what molecule they bind to, and the structure is just different enough that it's significant. So we convert our cholesterol into testosterone. Interestingly, that testosterone can then go a few different directions. One is it can be converted into estradiol, which is estrogen. This is how men produce estrogen because men have estrogen, but just at significantly lower levels than in females. And the enzyme that makes that happen are called aromatases. They convert testosterone to estrogen. They're mostly found in adipose tissue, which is interesting because that explains why men that gain a lot of weight and have issues with obesity tend to have higher estrogen levels, and that can produce some sort of feminizing effects because their estrogen levels rise because there's more aromatase there to convert their testosterone, so they wind up with low testosterone, high estrogen, and a bunch of issues that go along with that. The other option is you can use an enzyme called 5-alpha reductase, which is represented by this arrow, to convert testosterone into a very similar molecule that's not identical, but close, called 5-alpha DHT. DHT just being dihydrotestosterone because we've effectively added a water to it. That 5-alpha DHT binds the exact same receptor as testosterone, but with about 5 times the affinity, so much, much higher potency. All right, finasteride, our drug, is an inhibitor to 5-alpha reductase, so it's effectively preventing the conversion of testosterone into 5-alpha DHT, right, all throughout the body if you take it systemically. Right, this drug can be taken as a pill, as a oral medication, or it can be rubbed on the scalp as like a foam or a cream. The goal there is most men are not particularly happy about having their DHT levels decreased because it can make it more difficult to maintain muscle mass and bone mass and connective tissues that DHT stimulates the growth of. And so if you rub it directly on the scalp, these molecules are all fat soluble because they're made from cholesterol, which is a fat or a lipid. And so it can easily diffuse directly across the skin, enter the cells around the hair follicle, and have a more direct effect so you don't change systemic DHT levels nearly as much. All right, so the way this would play out in an actual cell is our testosterone molecule, which remember was made from cholesterol, so it's fat soluble. Testosterone can diffuse directly across the cell membrane, does not require any side of transporter or pump because it's fat soluble. So enters the cell, 5-alpha reductase would convert it to DHT. DHT will bind AR as androgen receptor. So these testosterone, DHT, these molecules are categorized as androgens, right? They have androgenic or masculizing effects. So once DHT binds to androgen receptors that are just sitting there waiting in the cytoplasm of the cell to be activated, once it binds DHT, then activated receptor enters the nucleus and acts as a transcription factor to turn on transcription of a lot of different RNAs. This could be genes in muscles involving increased protein synthesis for increased muscle mass, which is why taking testosterone supplements or drugs that mimic it are so good at building muscle. Does a lot of things. But you're turning on transcription of many, many different genes in whatever this target cell happens to be. All right. So in a hair follicle, the details of this from a cell biology level are pretty intense. So we can do a follow-up on it if you want to. But for right now, the short story is that the presence of DHT, specifically in men that have a particular genotype, so male pattern baldness is somewhat genetically inherited. So some men are more sensitive to this than others. But when DHT binds androgen receptor, the end result is that it leads to the shrinkage of hair follicles. There doesn't really seem to be an obvious biological reason for this, and so it appears to be, a bit of an evolutionary fluke, the fact that it happens like this. But the reason that we care is obviously most men want to keep their hair, and so if you apply topical or oral finasteride, you block 5-alpha reductase so that the testosterone surrounding the hair follicle is less likely to be converted into DHT. And that doesn't mean that you won't activate the receptor at all, because remember, testosterone still binds androgen receptor, but only at about 1/5 the potency of DHT. So we're not completely shutting off the signaling pathway, but we are pretty dramatically reducing its potency. All right. Okay, and as a quick aside here, I thought you might find this interesting, so I threw it in there. So the graphs that we're seeing are just showing that testosterone levels can change pretty dramatically over a lifetime. And the reason that you don't see male pattern baldness in younger men, like especially under the age of 20, is in large part just because their testosterone levels are fairly low. So the y-axis here is plasma testosterone. This is age. Obviously during childhood and early puberty, testosterone levels are fairly low. So there isn't really a whole lot of testosterone there that even could be converted into DHT. Fast forward to late teens, early 20s, testosterone levels get fairly high. This is about the time when, there's a lot of variation. Again, it's partly genetic. Some men make it through their 20s, 30s, even 40s without thinning hair or male pattern baldness. There are others. I knew, a friend's brother in high school that was almost completely bald by the time he was 18, ran in his family. And it really just has to do with how sensitive the cells in those hair follicles are to the effects of androgen receptor when DHT is present. Right? On average, testosterone levels fall off later in life, 70s, 80s, 90s. Most men that are going to be bald are probably already, short on hair at that point. But interestingly, there's data showing that, this is from a different paper, that testosterone levels don't really have to go down with age. And this was a pretty cool study where they took men and they put them through a screening process so that they only looked at testosterone levels in men that didn't drink alcohol or smoke cigarettes. They got enough sleep at night, didn't have any chronic stress or depression, anything like that. And if you filter for all of those variables, you don't see the decreased testosterone levels that you expect with age. There was virtually no correlation. So even men in their 70s, 80s, 90s had similar levels to men in their 40s. And so what it seems like is it's not necessarily age that changes testosterone levels. It seems to be behaviors that just happen to correlate with age. All right. Okay, so what are we going to use finasteride for? So I did a little bit of digging and found that this drug has been in use for a pretty long time. The first publication that I could find went back to 1992. They were looking at the effect on prostatic hyperplasia, and they showed a significant decrease in prostate volume. So to pick this apart, benign prostatic hyperplasia really just means benign, meaning not truly cancerous. There's no risk of it being malignant and spreading. And hyperplasia just means tissue growth. So basically harmless, albeit uncomfortable, growth of the prostate. And it's pretty effective for that reason. And all it really is saying is that prostate gland, whatever is making it grow, it's sensitive to androgen receptor activation. So if we can decrease DHT levels in those prostate cells, less androgen receptor, less growth, not incredibly serious, but again, the symptoms can be pretty uncomfortable, and it was effective for that purpose. All right. In addition to that, not anywhere near the same treatment, but same general time frame. Finasteride was also used for male pattern baldness, right, all the way back in the 90s. Right, this was published roughly 7 years after the prostate hyperplasia paper. And what they found was at 28 days out, the DHT levels in the scalp specifically were dramatically lower to the tune of about a third or so, a little less than half of the placebo group, And I didn't pull in all the figures because it shows exactly what you would expect. There's a significant improvement in hair regrowth, a decrease in hair loss. And so this became the go-to treatment for pharmaceutically treating male pattern baldness. Okay, but there were also follow-up second-generation drugs developed. This dutasteride is really has the exact same target. That's not different. But the difference between the two drugs is that, so there are actually more than one form of 5-alpha reductase. So think of 5-alpha reductase as a family of enzymes rather than a single specific enzyme. So there's type 1 and type 2 5-alpha reductase. And the effect of dutasteride is just broader. So it's not really about side effects. It's really about potency. So this is really just a more potent version of finasteride that decreases DHT levels even further by blocking both type 1 and type 2 5-alpha reductase. And so you would expect that you're going to get even further decreases in DHT levels. That should lead to less androgen receptor activity, and that should then lead to more significant hair regrowth. Right, so for this paper, they were doing basically a statistical summary, head-to-head, dutasteride versus finasteride, and assessment 6 months out. So pretty decent sample size, right? 600 patients and roughly 300 in each group. And then they're just following effectively hair density, DHT levels over time to see if there's a significant difference. Okay. And so the way this was mapped out is we're doing an incidence rate ratio and a confidence interval. So we've seen these before. This incidence rate ratio is very similar to what we've seen before when you're comparing a drug versus a placebo. The only difference here is we're not really comparing drug to placebo. We're just comparing two drugs directly to each other. And it was basically deemed that there's no need for placebo because we know that finasteride works. We're just trying to see if the second generation drug works better. Right? And so the way they did this is they had to have some sort of defining measurement of what constituted success. And they did that by saying first measured improvement in BASP, which is really just their classification system for measuring hair loss. And so when you read these stats, if any of these numbers came up as exactly 1, that would just mean that the rate of improvement for dutasteride would have been identical to the original finasteride, which clearly wasn't the case here. And so you read this as 1.5 times as likely to see improvement, 2.03 times as likely to see improvement on dutasteride compared to finasteride. Right? And the four different stats are basically categorizing people as having different types of hair loss just based on the patterning of it, which probably isn't a big deal for us. So that's the rate of improvement. These are our p-values. And unsurprisingly, the two data points where the error bars overlapped with the 1, they had insignificant p-values, 0.2 something, which means there's a 20-something% chance that this was just random, that two drugs really aren't better than each other. But there was a trend in a positive direction. For patients with these types of hair loss, they were significant, 0.29, which means there's a 2.9% chance that it was a fluke. But the consistency between all three of these or four of these groups, when pooling them together, I think shows pretty good confidence that the second generation drug is better, although you would need a bigger sample size to really prove that it's better in these patient subcategories. All right. Okay, well, that's what I've got for this week. I think it's interesting physiology and a good review of molecular interactions between ligands and different receptor types. So hopefully we can talk more about it soon.